ahead.
All right. Welcome everybody to this meeting. Just as part of introduction, GECHO is hosted by the Gastro Foundation in association with Project ECHO and University of New Mexico. The GECHO Fellows is run every second Monday at 6 o'clock. Dr. Hassan, mute yourself. Dr. Hassan will present and the chat will be open for questions as we go along. All right. So Hassan, is up to you now. At the end of the meeting, we will have some questions as well.
Can you see my slides now?
Yes, we can see your slides.
Hi, Karin.
Can you put it in slide mode?
Hi, Karin.
Yes, we can see your
Hi,
slides.
Karin.
We can hear you, Hassan. You can put it on presentation.
Just go onto slideshow. And I can see you sitting in the dark. Can you go to your first slide and then click slideshow?
Are you hearing me now?
We can hear you.
Yeah, we can hear
Are
you.
you
Go to your first slide and put slideshow.
Okay.
Yeah, that's better. You can start. You can go ahead, Hassan.
Okay. So, hi all. I'm sorry for the problem that we got just now. Now I'm going to start. Today I'm presenting eosinophilic oesophagitis. It will be presented by me, Hassan Ali. I'm I'm a medical fellow for University of Wits, Charlotte McKinney Hospital. So during my talk, I will give some introduction about oesophagitis in general. Then my talk, it will be like in a two section. The big one, or the most slide, it will be about the eosinophilic oesophagitis, and few slides about the other causes of oesophagitis in form of care, pills, oesophagitis, infectious type, and radiation. Or irritation of the mucosa of the esophagus. There are many causes of oesophagitis, and essentially the presentation is similar, which include retrosternal chest pain, heart pain, dysphagia. To be very cautious when we are taking the history, because the difference between the differential diagnosis, it might be very meaningful. Regarding eosinophilic oesophagitis, it is a disease. We can define it by chronic immune-mediated or antigen-mediated esophageal disease, characterized by symptoms related to esophageal dysfunction and eosinophil predominant mucosal inflammation. The prevalence is 55 cases for each 100,000 per population, and eosinophilic esophagitis is a disease of cold climate with wide range of egg distribution at presentation. It's more common among the white ethnicity and in male. But we can see a few cases in Africa here when we are practicing our fellowship. So regarding pathophysiology of eosinophilic esophagitis, eosinophilic esophagitis is a disease of a complex genetic cause, and inheritance is due to effects of multiple genetic loci that increase disease risk in a context of environmental and host immune factors. And there is a study that published in 2022 to address the genetic role in the eosinophilic esophagitis, and they can enumerate about 13 genes carry risk of eosinophilic esophagitis, and this expand our etiologic understanding of the disease and provide a frame for and
Are we all able to hear?
So, go back, previous slides. Go back. Back.
Go back.
I need the slides, the symptoms of esophageal. Yeah.
Yeah.
This is treatment.
We want that, the one below that, Hassan, we were on. Go down now.
Next one. Next slide.
Go down again. Next one. We were on this. No, next one.
No, next one.
Yeah,
Next
we
one.
finished this one. No,
Yeah,
we
this-
finished that one.
so-
So you are here now.
Yeah, so patient can present with food impaction because esophageal strictures, esophageal stenosis, and esophageal edema, esophageal mucosa. And patient can present also typically with retrosternal chest pain in some rate of patients. Typically, the patient does not respond to PPI. Food impaction is another important dominant feature in patients with eosinophilic esophagitis. And some patients also can present with reflux-like symptoms. So there is subset of eosinophilic esophagitis classification, which is based on the called endotype classification, which classifies eosinophilic esophagitis into E1, E2, E3. And this classification is very important for treatment as well as response to treatment. So for example, in E1, eosinophilic esophagitis, the inflammatory process is a bit mild inflammatory process. And in E2, there's severe inflammation with corticosteroid responsive genes. And in E2, there's severe inflammation with down expression of epithelial cells. So this clinical classification is histological classification is important and has got an impact on the treatment as well as the prognosis of patients with eosinophilic esophagitis. So when it comes to diagnosis, so history is extremely important. You're going to obtain family history of eosinophilic esophagitis. By the way, there's a familial type of eosinophilic esophagitis I mentioned earlier for the pattern of inheritance, particularly the X chromosome, and also is very common in twin patients. And history of food impaction, history of dysphagia, probably history of heartburns or history of reflux esophagitis are very important in patients with eosinophilic esophagitis. Then we do endoscopic examination of the patient. Endoscopy is important, have to be very careful because you can get proximal strictures. And these proximal strictures sometimes can easily be perforated. You can easily perforate the esophagus. And endoscopic findings are shown esophageal rings, and then this is called filling esophagitis and edema. You can get esophageal frost, you can get strictures, you can get micro abscesses, you can get even exudates. And you can get very tight strictures sometimes involving the upper esophageal sphincter more than the distal esophageal stricture. Usually to confirm diagnosis, we do esophageal biopsies. We take 2 to 4 biopsies.
So let me interrupt you there now. At endoscopy biopsies, where do you take the biopsies? Give us
the from the proximal esophagus, from the middle, and from the distal.
And anywhere else outside the esophagus?
And then we have to take biopsies from the stomach and from the duodenum to rule out eosinophilic gastroenteritis.
Right, okay.
And then we have to assess the historical features, that is the number of eosinophils. To diagnose it, usually we should get more than 15 eosinophils per high power field, or more than 60 per millimeter cubic eosinophils. And then you can get different pathological grading. I'm not aware about this ERFIS score prof. but as shown, it is edema or rings, exudate, frost, and strictures. And I think when graded accordingly, but I have no idea about this scoring system.
Do you know of any other clinical classification?
We know there's the IC classification, which is index of severity for eosinophilic oesophagitis, which is combination of clinical, endoscopic, and histological, and that scores the patient into inactive disease is called 0, and then 1 to 4, this is grade 1, and then from 5 to 7, this is grade 2, and then 7 to 15, grade 3, and then or grade 3, and then more than 15 is grade 4 or a very severe type. And it's combination of both. That is endoscopic, clinical, and histological.
Okay.
Go to next slide. Next slide. I think Hassan joined us. I can see Hassan.
Can you go to the
Yeah,
next
I'm
slide?
joining you.
Take from here, maybe.
Go to next slide.
Okay. Share. Present the mode.
Hassan, you are sharing your screen, so we can see your slides.
Okay. So for IRRIF's score, I think its significance is in the during the follow-up of the patient, so we can to see if the treatment make the grade that we discussed now is coming down or not, and it hasn't got any prognostic feature. So for esophageal biopsies, as Badruddin mentioned, that we have to know who and when and how to take the biopsies. As mentioned just before, we have to take biopsy from all stomach as well as duodenum to exclude eosinophilic gastrointestinal disease, and and the patient who's candidate for the biopsy, those patients who presented with very typical symptoms for eosinophilic esophagitis, specifically the food impaction or dysphagia. And the most important thing that I want to emphasize that the endoscopic picture, if we see normal endoscopic picture for the patient, it doesn't rule out the disease. Regarding histology, it is advised by British guideline to stop PPI just before 3 weeks before the biopsy.
Can you go back to the slide before that?
The previous.
Yeah, this one here.
This one.
Now.
Yeah.
Yes, I see.
So,
no, the one.
Yeah. So we have subgrades for each of the endoscopic finding. It is endoscopic scoring system for the patients. So for the edema, for example, we have grade 1 and grade 2. If we see this the very clear vascularity, so there is no edema. If there is absent or decreased vascularity, it signifies the presence of edema. And also it is very difficult. Sometimes easily we miss edema in such patients.
Hassan, your bandwidth is low. I suggest you switch your video off. Try switching your video off.
For the ring, we have grade 0, grade 1, grade 2, and grade 3. For grade 1, there is no ring. Grade 1, grade 2, moderate. For grade 3, severe, and the scope cannot pass the ring. For the exudate, we have 0, no exudate. My video, to put my video off.
Off. Put it off.
If I tried, I might lose the connection. Can I continue?
Yeah, continue. Your Reception is still bad, but try. Let's see. Have we lost him?
I think we've lost him, unfortunately.
I think let's just continue with Yusuf, and he'll just join as a guest. Okay, can you put your slides up?
So
do I need to share my screen again? Do you want me to put up the slides?
Yes. Share your screen again, and then when he comes back, we'll just let him to listen, and then he can at the end comment.
Okay, I'm sharing the screen.
Yeah, okay, we had gone past this. Go down again to the next one. Oh, sorry. Had you gone past this one here?
yeah, we did.
All right. Yusuf, you'll tell us where to stop then.
Yeah, okay, it's fine.
The
Yes.
rings, we were here. Do you want to go to the
No,
next
go
one?
more.
Go down. Next slide, Karen.
Next. Next. So the biopsy usually will show eosinophilic infiltration of eosinophils to the mucosa and submucosa with element of inflammation and fibrosis perhaps. And fibrosis may be the reason behind why some patients or most patients they present with dysphagia and foot infection. Could be sometimes as a consequence of the fibrosis and the inflammatory process going on within the esophageal mucosa as well as the submucosa. So having established diagnosis of eosinophilic esophagitis, so all patients should be treated. I'm afraid, Professor, I'm depending on the American guidelines. So maybe Hassan prepares them from British guidelines, but anyway, I think it doesn't make a lot of differences. So patients should be all patients with eosinophilic esophagitis who are diagnosed based on histology, clinical features, endoscopic features should be treated. And the baseline.
Sorry, are you on this slide here?
No.
Yeah, let's talk about this slide because what you're saying, it's actually jumped this slide. No, the one that you had on there. Karen?
Okay, Hassan's also just joined the Zoom again.
Yeah, I think let him listen so that we can finish.
Okay, just tell me next slide when you're
comment
ready
at the
to move
end.
on.
Yeah.
So we have other causes of esophageal eosinophilia apart from eosinophilic esophagitis. The most important one is gastroesophageal reflux disease. And in the past, gastroesophageal reflux disease was considered as one of the spectrum of eosinophilic esophagitis, but nowadays it is a separate entity. Achalasia as well can be a cause for eosinophilic esophagitis. And by the way, patients with achalasia, if they don't respond to surgical treatment after, for example, hilar myotomy, then one should suspect eosinophilic esophagitis in that group of patients. Eosinophilic gastroenteritis, eosinophilic colitis, definitely you can get involvement of the esophagus, but patients, they have other systemic features like diarrhea, like bleeding perirectum, or like that. Infective fungal or viral infections also, particularly in setting of high incidence of HIV, you can get patients also with infectious causes, and you can get eosinophil infiltration. Pill esophagitis also can be a typical feature. So these are the primary causes. Secondary causes, hypereosinophilic syndrome, drug hypersensitivity, connective tissue diseases, and perhaps helminthic infections, particularly Clistoma duodenal, Nicata americanus. All of them can lead to systemic eosinophilia. So this is differential diagnosis of eosinophilia other than eosinophilic esophagitis. So as I mentioned earlier, or as I mentioned, diagnosis is clinical, endoscopic, and histological. Constellation of all three components to clinch a diagnosis of eosinophilic esophagitis. So go next slide, please. Next.
Next slide, Karen. Yeah.
That should be the next slide.
Yeah. So eosinophilic esophagitis and gastroesophageal reflux disease, they can coexist. And I think 8% of patients with gastroesophageal reflux disease, they could have associated eosinophilic esophagitis. And this was the old concept that all patients should be given PPI before you take biopsies. But nowadays, the first-line treatment for eosinophilic esophagitis is proton pump inhibitors as anti-inflammatory as well as anti-secretory. So this information, I think, is a bit out of date, I'm afraid to say this. So next slide. So when it comes to treatment of patients with eosinophilic esophagitis, So the treatment is symptoms relief, that's a very important one, and then prevention of complications, and then dietary modification. So different guidelines, they have different approaches, but usually in the setting in South Africa and our settings here, I do prefer to start with dietary recommendations, dietary restriction, that is called the 6 food elimination diet, which is like sesame, like milk, like nuts. These medications, this type of food actually can improve if the patient deprived or stop consumption of this food. Definitely the symptoms might improve. And then usually we start with PPI as a first-line treatment. PPI must be twice daily, and then the patient after 8 weeks to 6 weeks, patient must be assessed endoscopically to see the response of treatment. So go to next slide. So proton pump inhibitors as a first-line treatment, we give twice daily dose, example like pantoprazole or omeprazole, standard dose twice daily for the duration of 8 to 12 weeks. And then on week 6 to week 8, we have to repeat endoscopy and to see the response of treatment. You don't need to repeat biopsy at this stage. You have to achieve clinical response phase, and then at week 12, you can repeat the scope, you can repeat endoscopy, and then you can assess for histology, and then you can see the number of eosinophils per hypo feed, and then you can speak about remission or failure of medical therapy. If the patient does not respond to PPI therapy as a first-line treatment, so the second-line treatment is usually, go to next slide. Second-line treatment is usually we use topical corticosteroids. And topical corticosteroids, either we use swallowed fluticasone, is very effective treatment, or we can use budesonide dispersible tablets. Contains, I think, 2 milligrams, can be used twice a day or 3 times a day. And the aim actually is to maintain or to maintain remission in those patients as well as symptom reliefs. If the patient does not respond to topical corticosteroids, some schools, some guidelines, they prefer the use of systemic corticosteroids. Prednisolone can be used in a dose of 0.5 to 1 milligram per kilogram body weight. It's very effective treatment, but don't forget usually to screen patient for virus B, hepatitis B virus infection before starting corticosteroids more than 20 milligrams. And don't forget to give calcium channel, to give PPI as well for these patients. And don't forget to calcium carbonate and vitamin D because they can develop osteoporosis and metabolic bone diseases. This is the medical treatment. Now, endoscopic treatment is recommended for patients who have strictures. So you have to do esophageal dilatation. At STPCO, we do prefer usually for patients with eosinophilic esophagitis to use bougies because they are safer than balloons and you can control the dilatation of the esophagus. And usually we try to maintain esophageal lumen more than 15 millimeters to allow the patient at least to swallow solid or semi-solid food. Usually dilatation, you have to do very careful dilatation because the mucosa is very fragile and easily can be perforated. So if you maintain esophageal lumen more than 15 millimeters and you maintain eosinophil count less than 15, the patient is going towards response. So the third line of treatment would be the new medications. So the first line is PPI.
Sorry, Yusuf?
Yes.
Yusuf, can you clarify that endoscopy? Because you're talking like you can just put it. What's the prerequisites for you to do endoscopic therapy?
Usually for symptomatic patients with food impaction or patients with repeated episodes of dysphagia, we do prefer to do endoscopic dilatation. Patients should be sedated, better to be preceded by barium to understand the anatomy and the topography of the esophagus. And then you have to do careful dilatation.
Okay, now my question was related to the use of medical treatment and endoscopy, the relationship. You can't dilate a person until they've completed a course of whatever medical treatment you put in because of the same reason that you worried about perforation. So you want the inflammation to go down, the friability to go down. Mm-hmm. So only after 8 weeks of steroids, only then can you go with the endoscopy. But if you do it before that, you're going to perforate. So that's the provision that you need. You need to have had the patient on adequate medical therapy before you go endoscopic. You don't start endoscopy unless there's impaction. You're just removing the foreign body. But generally, you should only follow medical therapy. Okay.
Now, apart from this medical treatment, so next slide, so we have the novel medications which are approved nowadays, FDA approved. FDA actually approved 2 medications. Dupilumab has been approved by FDA for treatment of eosinophilic esophagitis. It's monoclonal antibody and can be used effectively for patients who are suffering from eosinophilic esophagitis. Now, candiculumab and bendramizumab, I have no idea about these 2 new medications, but I know that omalizumab is nowadays in phase 3 trial for use in patients with eosinophilic esophagitis. So the approved one by FDA to be used nowadays and available in the US for treating patients with eosinophilic esophagitis is dupilumab, the number 1. So omalizumab is still in phase 3 trial, and maybe soon it will be available for clinical use in the market. So next slide. Next. Already I spoke about dietary recommendations. I spoke about the six food recommendation foods. That's the milk, wheat, soy, egg, nut, fish, and sesame. These are the 6 food elimination diet. Already I spoke about this.
Do you need to do that on everybody? Is there anybody that can use dietary manipulation without doing this 6 food elimination test?
We do testing. We test patients who are at risk or patient who has history of food allergy or environmental allergies.
Yeah, because if a patient can identify what food makes it worse, you don't need to go through this expensive stuff that you're talking about. So if they can tell you this is what makes it worse, then they stop that. Then you have your diagnosis. Go on.
Next slide, please. So yeah, we spoke already about this one. That is the bougies versus balloons. We use bougies better than balloons. The usual patient must be treated medically first. Okay, go next. Already spoke about this. So for refractory type of eosinophilic esophagitis, usually we need a combination of like multidisciplinary approach. Usually we involve dietitians for food elimination, and we continue with high dose PPI. You can combine even high dose PPI with topical corticosteroids. But remember, those patients can develop fungal infections as a consequence of topical corticosteroids. So you have to be careful about that. If the patient develop any opportunistic infections, particularly fungal infections, you have to keep a broad spectrum antifungal. We do use at BICO. Fluticasone is very good treatment for such patients. They respond very good to treatment. So repeated esophageal endoscopic dilatations is a good option for these patients. And you can repeat endoscopic dilatation every 2 weeks to maintain esophageal lumen more than 15 millimeters. So if you cannot maintain esophageal lumen more than 15 millimeters after 5 consecutive sessions of esophageal dilatation 2 weeks apart, so we label the patient as refractory eosinophilic esophagitis, eosinophilic esophagitis stricture. And the second line, I'm not sure, but I think he must go on to surgery. Next slide. So already we mentioned complications, strictures are the most important complications, usually proximal strictures rather than distal strictures. And the best treatment for esophageal strictures in the setting of eosinophilic esophagitis is repeated endoscopic dilatation, either balloon or bougies, based on your expertise as well as availability. I do prefer the use of bougies. Some other people, they do prefer the use of balloons. Dr. McConney, for example, he prefers the balloons over bougies, but usually I'm bougie man. So I think bougies for me is quite safe and I don't have any problems. Although some people, they argue against this, they say, for example, if you're using the balloon, then the balloon might be safer. You can observe the mucosa, you can know when to stop. And then if you perform any perforations already were in place, you can stent the patients. Those they have own justification for balloon use. Now coming up about esophageal dilatation, we have the endoflip. Is a new technique coming which will tell you the geometry of the esophagus, and actually it uses equation of esophageal dimension over the pressure. So you can have a very good information about the geometry of the esophagus, and you can use it in patients who are high risk to tightly control to dilate the esophagus to the target esophageal lumen, so 16 to 18 millimeter. Usually, I think, Prof, it is very difficult to maintain esophageal lumen at 18 millimeter. with patients with eosinophilic esophagitis, particularly long-standing eosinophilic esophagitis because of fibrosis and severe inflammation. But if you maintain it anything between 15 and 17, it will be quite fine for the patient to have at least soft diet or semi-solid diet without episodes of food impaction and dysphagia. So, next slide. Perforation usually is common, particularly if you do esophageal dilatation early, before 8 to 12 weeks after you initiate treatment, either topical corticosteroids or PPI. And usually perforation is very common if it is done with someone who doesn't know how to do esophageal dilatation. And also perforation is very common if you use big size balloon, for example, size 18, size 20. And if we start with large bougies, for example, 14, and you try to go. So usually the recommendation for this use is you have to follow rule of 3. That means no more than 3 incremental balloon size or bougie size in a single session. You start, for example, with 9 millimeter bougie, then 9, 10, 11, stop. Or you can start with 10, 11, 12, stop. Or balloon size, for example, 9, 10, 11 millimeters or PSI, and then you have to stop. So if you follow these protocols, that is the use of PPI or topical corticosteroids for a minimum of 8 weeks, and then you use rule of 3, never rule of 6 millimeter, usually rule of 3 is better. And then, of course, definitely the patient will be protected against infection, perforation. Remember, if there's someone who very expert in doing esophageal dilatation, better to be done by that person than junior people like me, for example. I'm not allowed. Next, please. Complications, so anxiety and depression due to persistent symptoms and social restrictions, and is alleviated by effective treatment. And then side effects of PPI, usually diarrhea, gastrointestinal infections, magnesium deficiency. Usually we think about how people, they forget hypokalemia, and then interstitial nephritis. Very common, of course, very important, not common, but very important side effects of PPI. And then you can then consider switching to alternative treatments such as diet and topical corticosteroids. Steroids also are a very effective, can cause the candida. I mentioned this already early. So you have to use antifungal treatment. Next. So that is just a proposed algorithm for treatment of eosinophilic esophagitis. I think we have mentioned all of the informations here, so I don't think we need to go through it again. Go next slide. The last slide.
No. Karen, more slides?
I'm moving to the next one. Oh, has it gone too far now?
Yeah, okay. I think we're done eosinophilic esophagitis.
Maybe because of time, we are raising against time. If you can give us some hints, some wisdoms about handling patients with eosinophilic esophagitis, would be more better than my rubbish talking.
Who should give you that wisdom now?
You.
Okay. Let's hear now. The virus, in the past 2 years, there's studies that have confirmed the genes and the viruses that causes eosinophilic esophagitis. It's not just viruses. Which one has specifically been shown to cause eosinophilic esophagitis? Well, they put viruses there. Which one? Choose. Confirmed. The others are just a theory.
Herpes simplex virus.
The HSV, that's the one that has been confirmed, isn't it? Now the problem is that when you have an ulcer from this thing, and you have more than 15 eosinophils per high power field, how are you going to manage that patient now?
So usually in the setting of herpes simplex virus, I will prefer to start with antiviral treatment first with PPI at the same time. And then if there's any intervention, we can do it after 8 weeks of therapy, combination therapy, antiviral and PPI.
Okay, that's correct. Now the genetic study that was done in 2022, there's lots of viruses that, genes that were mentioned, but there's one that has been confirmed, the one that we said is an X chromosome of males. Which gene was that? Which locus? On which locus is that gene?
I think locus 22.
No, 5Q22. Yeah, 5Q22.
Yeah, 5Q22. Yeah, 5Q22.
Yeah, does that explain the predominant male presentation?
Mhm.
I'm asking you.
Yes,
In what way?
because women, they have two X chromosomes. So if there's mutation in one chromosome, that X chromosome, the other chromosome can compensate, because this X chromosome, it encodes a specific type of proteins, which is thymic stromal lymphopoietin and its receptors. So the other gene can compensate for that lost gene, that mutated gene.
Okay, now my last question now, when you do serum tests in this patient, can you get any abnormality in IgE, and what do you accept as eosinophilic esophagitis, and what do you accept as eosinophilic syndrome?
If this IgG level is elevated,
IgE.
IgE, yes, IgE is elevated, along with eosinophils more than 15 per hyperfield from the esophageal biopsy. This in favor of eosinophilic esophagitis. If IgE is high and the eosinophil count is less than 15, it is in favor of eosinophilic syndrome.
Yes, if you have eosinophils more than 15. You know that in eosinophilic esophagitis, you get elevated IgE, isn't it?
Yes.
So what I want to know is which IgE would you accept as part of eosinophilic esophagitis, or will it be part of the hyper-eosinophilic syndromes, atopy and various other things?
Yeah, I know that the subtype of IgE goes with eosinophilic esophagitis, and a subtype of IgE that goes with hyper-eosinophilic syndrome. But honestly, I forgot.
I want that.
I forgot.
I forgot. Okay. Anybody wants to ask any questions?
Would you like me to stop the
Vigi?
share?
Oh, yes, just stop the sharing. Thanks, Karen.
There you go.
Okay, what's the risk of malignancy then, Yusuf and Hassan, if he's here in eosinophilic esophagitis?
The risk.
Hassan, I see you're back. You muted, Hassan.
I'm mute. Hi, Prof. I'm back now.
Okay, what's the risk of malignancy?
Oh, so I know, just I don't know the exact figure, but I know by after a long time with chronic inflammation, it put the patient at the risk of
Is that
malignancy.
so? Does anybody agree with that? Yusuf and Mudise?
Wait, Salam.
Sorry? There's no risk of malignancy, Hassan, right? None.
Okay.
I got that one. Anybody else wants to ask questions? You can just speak, otherwise I'll keep asking questions until 7 o'clock. All right. Karen, I think it's 7 o'clock now. Are we supposed to stop at 7?
You can finish at 7 if there are no further questions.
Okay. Any questions? Going? You're going to get this in the exams and in patient care. All right. Then it's up to me now to thank the presenters. That is both Hassan and Yusuf. And thanks to ECHO and University of New Mexico and ECHO India team for the support. The recordings will be available on the Gastro Foundation website, and thanks to Gastro Foundation as well. Are we happy? Can I close the meeting?
If you could just advertise the next session, please.
Sorry, the next session will be on Monday, the 6th of May, 2024 at 6 o'clock. The presenters, I guess, will be circulated at that time.
Well, the topic is approach to upper GI bleeding, varicose, and the presenter is Desiree Moodley.
Is that a surgeon or a medical?
She is medical,
She's medical.
but we do have Mark Bernon as the chairman for the topic.
Oh, for them. Okay, that's good. All right. Can we close the meeting and have a lovely evening? And Hassan, you must move to a place that has electricity, no?
Shame, I think we really need to say thank you very much to him.
I
It's been a very
moved
trying
to
session.
Barabdorf to build the power because we have a problem in Charlotte. But
Yeah, no,
unfortunately, we
Shema.
have this problem.
I understand. Joburg is a
Yeah.
poor place. You must come to Pretoria, Ali. Thank you.
Okay.
Thanks,
So
guys.
thank
You
you for that.
can. Anybody saying something?
I was just going to say good night, everyone, if we finished now.
All right. Thanks, Karen. Thanks. And thanks, Hassan, for all the attempts you did to present. Thank you.
Prof. Thank you, Prof.
And thank you, sir, for helping him.
Bye-bye.
Bye.